Time for some clinical peanuts.
There's a patient complaint of the watering and redness for 1 week, which is not associated with uh, uh, pain, photophobia, any uh, complaint of joint pain, no previous similar illness in past, and no positive family history. The left eye seems to be normal. The right eye, there is a mild periorbital swelling with mild congestion, chemosis over conjunctiva, and there is a stained positive area over the cornea with mild haziness. And then the pupil is NSNR with lens clear and fundus clear.
Okay, Shubhangi, would you like to describe the corneal lesion?
There is a corneal erosion with dendritic form of stain positive uh, over the cornea with terminal bulbs seems to be.
Yes, Dr. Pratima, you can take over, please.
So, as we can see, this is a dendritic corneal lesion, basically HSV epithelial keratitis. So, it is very important in these conditions that we first stain these lesions and see them properly. Like you can see in this clinical photograph that the base is taking up the fluorescent stain, and we can even do a rose Bengal staining wherein the margins will usually take up the rose Bengal staining, and we can have a double staining. The corneal sensation should also be checked in these lesions, and it is very important that we don't start steroids, and only cyclovir eye ointment would be good enough for treatment of these lesions. Cyclovir eye ointment 5 times a day or ganciclovir 3 times a day for 14 days. And after 14 days, we can just check whether the lesions are resolving or not. If they have resolved, then we should stop it right away. And if not, then we can maybe continue up to 1 more week and then see if it is still not resolved. Then we can go ahead either with epithelial debridement. Sometimes, rarely, these conditions can require steroid at the end of, like if it is not resolving at all, if it is not because of the virus, but because of the inflammation. But it is a very rare scenario. Usually, they do subside with topical antivirals. So, anything else anyone would like to ask about these epithelial HSV epithelial keratitis? Am I audible? Hello? So someone has asked in the chat box that what is the difference between HSV and HZO? So these lesions which are in HSV are true dendrites, and HZO will have pseudodendrites. The HSV lesions will have some knobbing at the end, while HZO will not have that. For treatment part, almost the treatment would be the same for epithelial keratitis, not very different. And for HZO, am I still audible?
In between, we
Yes.
had lost you. Now
Oh,
you're
okay,
audible.
okay. Okay, so what if both the epithelium and stromal components are there? So someone has asked in the chat box that what if both epithelial and stromal components are there? So if both epithelial and stromal component is there, we need to first treat the epithelial component, like we will give topical acyclovir, and then we can move ahead with the stromal component also. Like we have to start topical acyclovir along with systemic acyclovir 5 times a day, 400 milligram. And once the epithelial component starts healing, then we can start topical steroids also in these cases once epithelium is means the complete lesion has healed. Also, I would like to emphasize that okay, so someone has asked, should we give systemic antivirals in epithelial keratitis? So usually in epithelial keratitis, systemic antivirals are not required. Only topical antivirals suffice. But yes, as I said, if it is a mixed component with epithelial, stromal, endothelial, then in those cases, systemic antivirals would be required. And later on, we have to start topical steroids also. Also, I would like to emphasize one point that whenever it is epithelial lesion, like when we are ruling out pseudodendrites, then we have to rule out other conditions also, like apart from HZO. Sometimes patient might like come up to your OPD and they might have just dendritic lesions, but it might have a wave of epithelium around it. So you have to rule out healing corneal epithelial defect. Sometimes it might also appear like epithelial keratitis. So HSV epithelial keratitis. So first you have to rule out healing epithelial defect, then HZO. Sometimes even fungal keratitis, very initial lesions can appear like dendritic lesions. So we have to rule out those also. And acanthamoeba, even that can have those radial perineuritis, and those early acanthamoeba lesions can also appear like HSV epithelial keratitis. So you need to rule out those also. So pseudodendrites are very important. Like many people will start treating them as HSV, and they might like especially if it is like a healing epithelial defect, and you start giving topical antivirals, then they might worsen also, and they might lead to persistent epithelial defects. So you have to rule them out and see whether it is actually HSV or something else. So we have many questions in the chat box. I'm going through each and every of them. Like next question was
I
any
think Dr.
difference between
Shubhangi, you can ask questions because she's the presenter.
yeah.
You cannot.
So Shubhangi has asked one question in the chat box, like difference between stromal versus interstitial keratitis. So, like mainly these things we clinically when we see stromal versus interstitial, you might not see a very huge difference. So you have to like see for the other signs also like DM folds and accordingly, like if there is a diffuse stromal edema along with DM folds, it might lead towards a stromal keratitis diagnosis. And how would a patient with epithelial, stromal, and endothelial keratitis look? I mean, the signs. Someone has asked. Sarah George has asked this. So epithelial, stromal, and endothelial keratitis. So, like, I think Sarah is asking about each and every one of them. So, epithelial, as the photo had shown, that it will have dendritic lesions. Stromal, it will have just stromal edema along with DM folds. And endothelium might have stromal edema, DM folds along with KPs. And sometimes even AC cells might be there if there is some amount of iridocyclitis involved, and the IOP might also increase in these conditions. So, and then sometimes there can be a mixed picture of stromal with endothelial, stromal with epithelial. So you have to look for that also. And someone has asked Dr. Asira, what would be the dose and duration for systemic antivirals? So the dose for the acute infections would be 400 milligram acivir 5 times a day, and for 2 weeks, followed by maintenance dosing of 2 times a day. It might be continued for 6 months. If in case the patient is having multiple recurrences, we might need to continue this for 1 year, 2 year, and sometimes even lifetime, depending on the level of recurrences, level of the lesions, and if like supposingly some patient is requiring some, rarely we do need to perform a PK, then also we need to give the systemic antivirals for a lifetime duration, maintenance dosing of systemic antivirals. How many follow-ups are required if patient is compromised? So if someone is asking how many follow-ups are required if the vision is compromised also. So it depends on the severity. Like if the lesions are very severe, you think that there is a lot of infiltration, there is necrotizing HSV keratitis, then you might need to follow up these patients regularly. Even I have followed patients daily if I feel that there can be a lot of thinning, means there is necrotizing epithelium, HSV keratitis, and there is thinning, the inflammation is very high, it can perforate or something, then you might need to follow this patients early. But if the inflammation is not very high, if the lesions are like resolving, you have seen the patient in maybe 3 days, 1 week, and the course is fine, then you can even follow up these patients with tapering dose of steroids for epithelial keratitis. If you are not giving steroids, then you can call these patients directly after 1 week and then 2 weeks. And for any stromal keratitis, if the lesion is gradually resolving, you have kept the patient on tapering doses of steroid, you can call these patients even after 2 weeks, 3 weeks, depending on your tapering and the amount of inflammation and how much the lesions are progressing or decreasing. So someone has asked about HSV studies. So mainly you can go through head studies, for these, like there was
Yeah.
heads 1 and heads 2
Doctor, you
trial.
can ask these questions to the presenters. This is a case discussion,
Yeah, so
so
okay,
you
okay,
can
okay.
ask and then you can discuss.
Okay, so
Dr.
I think
Shubhangi is
Shubhangi
there.
can take up
Yeah.
HSV head studies for like Dr. Aruna Palla has asked about head studies and HSV, other HSV studies. So can you take it up, Shubhangi?
I have no idea about it.
Okay, so I think I
No,
will
no.
share.
When you are presenting the case, Shubhangi, you haven't read also even a word. You saying no idea.
Sir, I've studied, but I'm not at this moment.
So,
I'm not remembering
so
the.
this is a platform to make mistake. If you say, you will learn more, and Dr. Pratima is there to correct you.
Yeah.
So whatever is your confusion, please go ahead. Whatever you have read and whatever you think, how will you like to manage this case is there in front of you, and why?
Shubhangi, you can say anything, like whatever you think about this case and how would you diagnose it. I have already explained, so you can tell accordingly.
Ma'am, after staining, it is clear it's a dendritic form of ulcer. So maybe viral keratitis. So we add eye ointment acyclovir for 5 times, 5 times per day for 1 week, and then look as it is, and add lubricant, a good lubricant for it, and can give antibacterial coverage also, ma'am, and give oral acyclovir as you ma'am told that 800 mg 5 times a day, and then after follow up every 1 week.
So,
That's
as I said, oral acyclovir 800 milligram is for HZO, first of all. Okay, 400 milligram, it's is for HSV. Okay,
mm.
and then for epithelial lesions alone, you don't need to give any oral antivirals. Then again, lubricating eye drops usually are not required. It can be added just for the sake of patient comfort, but usually not required in these cases. And also antibacterial cover, it's a little bit of controversial thing. Some people would give antiviral, means antibacterials along with antiviral, like chloramphenicol, soft drug like chloramphenicol, but usually it is not required. If like you are giving lubricating eye drop along with antiviral, it is usually more than sufficient. But some people, yes, do give antibacterial cover also, just for the sake that if it can get a secondary infection because there is a open epithelial defect, usually not required. Then like what are the special stains which you know about and you would like to go ahead while diagnosing this patient?
Ma'am, first sodium fluorescein, and then rose bengal, ma'am.
Yeah, and any other stain you would like to comment upon?
Lissamin green.
Yeah. So earlier we used to do only rose Bengal staining, but now ahead means nowadays you can also go ahead with Lissamin green staining. And if you are going to go, do a culture, usually we don't go ahead and do a HSV culture for the diagnosis of HSV epithelial keratitis. But if you're planning for any of the cases that you are going to do a HSV culture, then rose Bengal staining can devitalize these tissues, and they can like kill the virus within the tissue. So if you are planning for HSV culture, then avoid rose Bengal staining. But if you're not going to like scrape the epithelium for diagnostic purpose, then you can go ahead and just see how the rose Bengal staining pattern is, and how is the double staining pattern.
Ma'am, I have a question regarding this. May I please ask?
Yeah, sure.
Initially, I mean, there are two schools of thought about it. Some people do
Yeah.
believe in scraping the epithelial keratitis, like the dendritic ulcer, to reduce the viral load. But then the other
Correct.
school of thought is that some people believe if we do that, we might end up pushing the virus into the stroma. So, I mean,
So
we
I
do
would
this.
say that you don't need to go ahead with the epithelial scraping debridement in all the cases. So what you can do, you can start with the topical management. See if the epithelium is healing or not. How are the margins? If the rolled up margins are like healing, if the size of the epithelial defect is decreasing, then you can simply go ahead with a topical treatment and avoid any debridement. But if after, so say after 1 week, there is no resolution, you think that the margins are heaping up rather than healing, so in those cases you can just remove, debride the margins of the defect, trying not to increase the size of the defect as much as possible. Don't increase the size of the defect. Usually it doesn't go into the stroma, means the virus doesn't drive into the stroma, but the main purpose of the debridement is that if the margins are heaping up, it is not healing, then it helps. But not required in all cases. I would say maybe 5 to 10% cases might require debridement, but not always. You can see the course, like 80 to 90% would heal on its own once you start topical or cyclovir. Okay,
Okay, ma'am. Thank you. One more question. What will
sure.
be the first sign of the healing dendrite that will we see? It will be reduced stromal infiltration, or
It
is
would
it
be
that those heaped up cells they will like come at level?
the size of the defect itself would start decreasing. That would be your first sign. That, like, if you see the patient in 3 days and the size of the defect is decreasing, size of the inflammation, means the density of the inflammation is decreasing, then itself it shows that it is healing. So you can just continue your treatment and see that up to at least 2 weeks you continue, and then you can see if the defect is completely healed or not, or you need any kind of augmentation, like either you need to continue antivirals for 1 more week, or you need to just start lubricating eye drops along with it, or you need to debride or something just to complete the means healing process.
Yes, ma'am. And ma'am, something about you just said like 2 minutes back that 800 mg dose is given in cases of HZO. Ma'am, but
Yeah.
what about necrotizing stromal keratitis? In that also, do we go for 800 dose or 400 is enough 5 times a
We
day?
start with 400 milligram. Even I am sometimes confused about the necrotizing part, because usually we would give 400 milligram 5 times a day. That should be means sufficient, but you can increase it if supposingly there is no healing. You can see that there is no effect at all. Then you can increase it up to 800 milligram.
Yes, ma'am. And ma'am, also when you
And
said
then you also, one more thing, when you see that there is no healing, sometimes necrotizing stromal keratitis itself can have a secondary infection. So it is very important to scrape and see the lesions if there is any kind of secondary infection, like with maybe say acanthamoeba or any kind of bacteria. Sometimes that also can be leading up to non-healing defects. So you have to rule them out also.
yes, ma'am. And last question, ma'am.
Yeah.
You were saying ki in epithelial keratitis, it is usually not an indication to start oral antivirals. But what
Yeah.
about patients who are contact lens wearers or who have a history or in children?
In children, like you can see again, usually antivirals topical would be enough. But in children, if you can see that there are some blisters around the eye, if it is a bilateral condition, then you can start oral cyclovir also. Otherwise, not necessary. For patients with contact lens wear, again, not necessary until unless they are having some stromal lesion also.
Thank you, ma'am. Thank you.
Yeah, welcome.
I think what Dr. Pratima is saying is it is preferred to use topical because it is easy and safer.
Yeah.
But yes, acyclovir oral also can be used if it is, yeah, because
If it
but
is
both
not healing.
we don't need to use both, like
Yeah.
topical as well as
Yeah.
this. And because it is easily available in India and it is a less toxic and less systemic absorption, so topical makes sense, right, Dr. Pradima?
Yeah. Correct.
So,
So,
Dr.
Is
Shubhangi,
it
how will you like to scrape? Which area would you like to scrape in this? If you have to send for scraping, would there be a particular area from where you would
from the
like to
border,
scrape?
from the borders, margin of the ulcer.
Or in the bed? Or where is the viral load?
Sir, at the margin of the ulcer, sir.
Dr. Pradima, would you?
Yeah. So mainly the HSV viral load is, as she rightly said, is in the epithelial means borders of the ulcer. So while scraping, it is very important to take the borders of the ulcer. But if you want to rule out any other kind of infection, then you can take both the borders and the base of the ulcer. If you are thinking that maybe it might have some other secondary infection also.
Ma'am, I have a question.
Yeah.
Ma'am, few days back, I saw a patient who is who has been diagnosed as viral keratitis from outside. She consulted in our OPD. At first, there is a few SPKs, and then there are a few KPs over in KPs. So, ma'am, how I have to manage that patient because stain is positive, we can't start steroids. So,
So
I
how
think,
to
Dr.
manage?
SPKs are
Pratima,
there, you're saying?
maybe you can start with the head study. You can give them
Yeah,
a
for
head
sure.
start about the head study. Dr. Shubhangi, you can
Yeah.
tell us some points, or maybe someone else can tell us some points, and Dr. Pratima will always correct or refine it if needed.
Sir, in HETS1, there is topical steroid is used in stromal keratitis, and there is one more study that says ki, oral acyclovir is not of much benefit in stromal keratitis. That's
So there are like main you can divide head study into heads 1 and heads 2. Okay. So in heads 1 there are multiple components in the study. So first one is that I would like to share the slide also just so
Yeah,
that
please go
people
ahead.
can
Go ahead. Go ahead.
understand it better.
Yeah.
Just one second. Okay. So can you see the slides?
yes, ma'am.
Okay. So as you can see, um, so there's this heads 1 and heads 2. So we are now seeing heads 2. Just one second. Okay. So in heads 1, there is the study wherein they did like studied for the stromal keratitis, not on steroid trial. So what they did, they evaluated the efficacy of topical corticosteroids in the treatment of HSV stromal keratitis in patients receiving concomitant topical antivirals. And they found that the patients in the steroid group had faster resolution in stromal keratitis. So the first like result of the study was in stromal keratitis, as you rightly said that the steroid had better resolution. The patients receiving steroids had better resolution. Then in HEDS SKS, that is stromal keratitis on steroids trial, what they did is they evaluated the efficacy of oral acyclovir in treatment of HSV stromal keratitis. And what they found was that there was no beneficial effect of oral acyclovir. Now, it is like, would we still add oral acyclovir or not in cases with HSV stromal keratitis? So it is a pinch of salt kind of thing. If you are giving steroids in these cases, always better to add oral acyclovir along with topical steroid. Then there was this iridocyclitis trial where they found that oral acyclovir may be beneficial in cases with iridocyclitis, but in these cases the small sample size was smaller, so they could not conclude it completely. So it is always better in cases of stromal keratitis and iridocyclitis to start oral acyclovir along with topical steroids. Then there was HEDS 2 trial, wherein in the first trial they they checked for epithelial keratitis whether acyclovir was beneficial or not. So they found that there was no beneficial effect of oral acyclovir. So as everyone were asking whether oral acyclovir would be beneficial in cases with epithelial keratitis, so there was no added benefit. Yes, in some cases, if there is some reason where you cannot give HSV, means this or topical oral, topical acyclovir, then maybe you can try oral acyclovir. But usually, I would never come across such cases. Usually, I might come across cases wherein I cannot give oral acyclovir due to some reason, and I have given it only topical, and it might help even in cases with anterior stromal keratitis that only topical acyclovir was given and it was still beneficial. So oral acyclovir in cases of epithelial keratitis is not required. Then acyclovir prevention trial was done, wherein they found that oral acyclovir significantly reduced the probability of recurrence in cases. Like whenever they gave oral acyclovir, the chances of recurrence was lesser compared to those cases wherein oral acyclovir was not given. And this is another study, recurrence factor study, where they checked for the psychological factors and if there is any other environmental factors, biological factors related to HSV, and they found that it is not exactly related to the recurrences. Multiple HSV stromal keratitis episodes will markedly increase probability of like whenever there is one recurrence, it can increase the chances of further recurrences also. But apart from that, environmental factors, psychological factors did not have a very high effect on the HSV ocular recurrences. So, this is all from my side for the HEADS trial. If anyone else wants to add in something.
Yeah, thank you, Dr. Pratima. So now, Dr. Shubhangi, so what you need to remember is in this they have not compared topical acyclovir with oral acyclovir. When this study was done, there was no topical acyclovir available in US. So this study was basically comparing whether instead of giving topical trifluridine, we can use oral acyclovir. Okay, but in India, because since topical acyclovir was always available, hence for us this study doesn't make any difference between oral or topical. We'll always prefer a topical treatment. But what they were comparing was between trifluridine, because trifluridine is very much epithelial toxic, which even acyclovir is. So that is why the comparison is there. And that is why the confusion is there, because people think that in this study also topical acyclovir was used, but that was not the comparison.
Yeah.
Okay, Dr. Shubhangi.
Yes, sir.
Yeah. So obviously, whenever we talk about treatment of epithelial lesion, it is always by default topical acyclovir. But yes, because as they have proven that oral acyclovir, if needed, can be used.
So someone has also asked why topical antivirals are in the form of ointment and not drops. I'm not very sure of that answer because like it's mainly formulation whether the CP, I mean, the medication can survive usually in the ointment form versus drops form. But I'm not very sure particularly about acyclovir why it is not available in the the drops form. Anyone else want to take this question?
Maybe whoever has asked can find out and tell us why it is so, because we are not aware. Maybe something to do with the pharmaceutical preparation, but
Yeah.
it's an interesting question.
Yes, yes.
But yes, even
Yeah, very
ganciclovir
interesting.
gel is available. It is not available
Yeah.
as drops.
Yeah. So someone has even asked, should we give cycloplegics? So yes, in cases where we have iridocyclitis, then we have to give cycloplegics, especially like atropine would help in these cases, atropine or homatropine, anything you can give according to the amount of inflammation. Um,
So
is
Dr.
there a
Pratima,
role of antivirals? Someone is asking adenoviral conjunctivitis. So usually not. In adenoviral, usually acyclovir, many people will give acyclovir 5 times a day eye ointment, but usually not. For adenoviral conjunctivitis, lubricating eye drops alone would be enough. And if supposingly it is not resolving, and there are like, I keep three factors: chemosis of conjunctiva, if there is any like nummular lesions of the cornea, or if there is membrane, then I would give steroids also. But otherwise, lubricating eye drop alone would be sufficient and no need of antivirals. You're saying something?
Yeah. So, is there any pointers like how we can differentiate between a HZO dendrite and a HSV? Or would you like to tell us something about it?
So when you see the structure of the dendrites, as like in all, you would read that the ends would be knob-like in HSV, and the dendrites would be much more thinner in HSV. The overall dendritic size would be, means each branching would be much thinner compared to the pseudodendrites which are seen in HZO. So these are the main pointers for differentiating between HSV and HZO. Then again, if you have to see the face of the patient also. Sometimes the lesions would be very subtle, okay, involving only one side of the face, very subtle lesions, small, sometimes even small amount of scarring can be seen. Like the lesion might have healed, the patient might be coming after 14 days or so, and there might be subtle scarring at one side of the face. So even that can lead you to HZO compared to HSV. So you have to look at the face of the patient also, and then you can find out means the difference much better.
Okay, thank you.
Okay, ma'am,
So,
I have a question.
yeah,
Achha.
please go ahead, Dr. Aishwarya.
So, ma'am, there is a lot of confusion with this nomenclature, but if when we're talking about HSV and we are saying it is stromal without ulceration, that is stain is negative, then doesn't it
Mhm.
include the immune mediated or the interstitial or the non-necrotizing, like all of these categories? It's all the same thing, right?
Yeah, so if it is like, if you see Krashmers, there will be multiple nomenclature to one thing. Okay, so like they have named one condition, given multiple names to single condition. So you just divide it into stromal keratitis, whether it is immune mediated or if it is necrotizing. If it is necrotizing, treat it according to the necrotizing format, and if not, if it is like the epithelium there is no defect in the epithelium, the inflammation is less, there are no infiltrates within the lesion, and there is just stromal edema with descent membrane fold, then treat it like an immune condition. It can just have an immune ring also. So you need to differentiate. Then you need to differentiate it from acanthamoeba again, whether it is a acanthamoeba associated immune ring, fungal associated immune ring, pythium associated immune ring, or HSV associated means sorry, not immune ring for these three conditions, but any ring infiltrate for these three conditions versus HSV immune ring.
Yes, ma'am. And ma'am, when we're talking about HSV keratouveitis or we're talking about endothelitis, it's the
Yeah.
same thing, right?
No, so not exactly the same thing. Sometimes, like there will be HSV endothelitis, and they will have no cells. You will see them clearly, and you can see just the endothelial means there are KPs over the endothelium. DM folds are there, stromal edema is there, but cellular reaction is not there. There is no raised. The IOP will be normal in such patients. But in HSV keratouveitis, when you see, there will be a lot of cellular reaction also. So in these patients, you have to, the IOP might be also raised. So in these patients, you might need to start anti-glaucoma medications along with a lot of steroids. Like for endothelitis, if you're starting maybe 6 times steroids or 8 times steroids, for keratouveitis, you might need to start hourly steroid and then taper down.
Yes, ma'am. And ma'am, steroid of choice is prednisolone, not dexamethasone.
For me, it's prednisolone. Like prednisolone, like when you study pharmacology, you will read that dexamethasone is more potent than prednisolone. But when you read for ocular pharmacology, then you will see that the prednisolone potency is higher than that of dexamethasone. So for these conditions, always better to start prednisolone 1%, which would be the drug of choice.
Ma'am, it will be really helpful if you could find us some paper or where this is mentioned, the prednisolone, dexamethasone.
For sure, I'll find
Ocular
out and I'll share for
pharmacology.
you.
Yes, ma'am.
I had found it recently, but now I have to check that whether I can find it again or not.
So
And ma'am, in
the
cases of
penetration is
stromal
definitely
keratitis.
more with prednisolone,
Yeah, prednisolone. The
but there is
potency and the
no
penetration is
direct
better.
head-to-head comparison yet.
Yeah.
It is
They
just
don't
that
have a study of comparison between
yes,
dexamethasone versus prednisolone.
yeah, Dexa is the most potent even Hydrocortisone is more potent, but prednisolone has better penetration. And second thing is you have to understand pharmacology and you have to understand pharmaceuticals. If there is no
Yeah.
dexamethasone available, then nobody is going to use it. So what we are talking is everything which is coming from US. Okay, so if they don't have a dexamethasone molecule which is available, then you will not have any comparison. Okay,
Yeah.
so dexamethasone recently in India also as a what do you say, as a solo molecule has started recently in India. Till now we could only have a prednisolone as a isolated molecule. Dexa was always available with a combination. And over past 1 2 years, we have a dexamethasone which is available as solo. So there is no comparison between dexamethasone or prednisolone or even diflupred because there is no comparative study between them to know which is better. Obviously, the prednisolone has its issue because of the residue which is there. So it is less cosmetically appealing to people who are working, and this so dexamethasone is more having better compliance compared to prednisolone. If person is going to office with a prednisolone, then they don't like to have the residue on their eyes, which is whitish thing. But we don't know which is better. But yes, as Dr. Pratima said, every book will mention prednisolone because that is the only molecule which is available.
Yeah.
Yes, sir. Yes, ma'am. Thank you.
So, Dr. Shubhangi,
Sorry.
would you like to tell us how to differentiate between a necrotizing and a non-necrotizing stromal keratitis? I think Dr. Pratima has already told.
Sir, in necrotizing, there may be an associated with endothelitis, epithelitis,
Yes. So
and
what will happen in epithelitis?
the stain positive.
Yes. So if there is a epithelial lesion, right? So
Mm-hmm.
that is why then you will not use a
Steroid.
yes, or you may have to use it under cover. Dr. Pratima, would you like to add more on to the stromal necrotizing and non-necrotizing?
So I think I have covered almost all the points which like I'm aware of for like stromal versus necrotizing. I think beyond that I can't add much to that.
Okay.
Yeah.
Yeah.
Ma'am,
Any other
even in
question?
stromal keratitis,
Or
when sorry, even in stromal keratitis, when there is no epi defect and we have a definite stain negative, some people still start topical acyclovir for 2 days and then they start steroids along with oral acivir.
so there can be different school of thoughts. If it is only anterior stromal involving, you can try topical. But usually for stromal, the recommended would be to start oral acyclovir right away. And you can even like if you are sure that it is HSV and not something else, like you are sure that it is not a mixed infection or something, you can start steroids right away also. But if you're not sure, then you can wait and watch for 2 to 3 days, start oral acyclovir. If you want to add on topical, then you can do that, but it is usually not required. And then you can start steroids maybe after 3 days if you can see that there is some definite improvement in the lesion, or at
Yes,
least the symptomatic there is some symptomatic relief. You can see that the patient is like symptomatically better. Then you can start steroids, observe the patient closely and see.
yes, ma'am. Thank you.
So, Dr. Aishwarya, as you said, if it is immune mediated, the mainstay of treatment is obviously steroid. The need for acyclovir is to prevent any recurrence or epithelial involvement. If the patient, because this is a case of immune mediated, so patient already has the virus inside, so it should not reactivate. So whether if you are giving topical also, then you cannot use it for a long period of time, even if it is penetrating or having an effect. You cannot use it for more than 2 weeks. And we know that stromal keratitis, you will need treatment for a long period of time. Now, when we are talking about using steroids in cases of stromal keratitis, it is not for 2 weeks to 1 month. We are talking about over more than 2 months. We are going to use them on topical steroids with a very slow tapering. If we are starting with 1 hourly or even 10 times, then we may be tapering weekly or every 10 days. So the treatment is going to be at least 6 to 8 weeks minimum. So we cannot use a cover of topical antiviral for so long, because even if there is no activity, you have to cover with a antiviral so that there is no reactivation of the virus. In a case of stromal
Yes.
immune mediated.
Yes, sir. Sir, please correct me if I'm wrong, but
No,
I
the
read
expert
that,
is Dr. Pratima. You have to ask questions to
uh,
Dr. Pratima.
ma'am, I read it once somewhere that whatever the condition, I mean, I don't think we can use topical antivirals for more than 2 weeks, and the steroids, as
Yes.
sir said, have to be tapered over a period of 10 weeks. Is that right, or am I wrong? I mean, I don't know.
So it's not hard and fast that you have to taper over 10 weeks only. But yes, as you said, after 2 weeks, there will be chances of epithelial toxicity. And so we should avoid using topical antivirals more than 2 weeks. Sometimes, yes, we do give 3 to 4 weeks also, but it is better to avoid beyond 2 weeks. Okay. Then, secondly, like as you said, so what is the second part of the question?
Just these two things, ma'am, that the topical antivirals for
Yeah.
2 weeks
So
and
the
steroids
10,
to be tapered over 10
yeah, yeah.
weeks.
So the steroid tapering over 10 weeks is something which depends on the amount of the lesion, the amount of reactivity. If you are seeing that the patient has just a little bit of small coin shaped stromal keratitis, and you can taper over, like you have started just 4 times or 6 times, and then you are tapering even at 6 weeks or 8 weeks, you can stop the steroids and see if there is no recurrence and the lesion is completely resolved maybe in 4 weeks. Then you don't need to prolong it for 10 weeks compulsorily. So basically, it depends on the amount of the lesion, amount of the depth of involvement. It's not a hard and fast rule. You might even need to taper it over 2 months. If sometimes it even 10 weeks, beyond 10 weeks, you might need to taper it very slowly, that maybe you are giving it 4 times 2 weeks, then means 6 times 2 weeks, then 4 times 2 weeks, something like that. And it depends, like if it is a recurrent lesion versus a new versus the patient has come to you for the first time. Okay, so if you are seeing this patient over a long period of time and you know that this is the third recurrence of the patient, then you might need to slowly taper it, maybe beyond 10 weeks also. So it depends on the amount of the lesion.
The amount of the lesion at the time of initial presentation
At the
and
time of
the
initial
subsequent
presentation, at the
improvement.
time of presentation to you, at that point of this is like the
That
third
specific
recurrence.
episode. Okay.
Yeah, that particular episode.
Yeah.
Okay.
Yes, ma'am.
And one more thing, when we are using topical, if we are using for stromal, so with the epithelial toxicity, if the epithelial toxicity kicks in and you are not an expert like Dr. Pratima or Dr. Raghav, it will be very difficult to pick up whether this is epithelial reactivation, activation, or it is just toxicity.
Yeah.
So that also again leads to a lot of confusion, whether you stop now steroids or you stop the antiviral, what to do because there is epithelial lesion, should you continue it? So it is always better to stop it at a particular point or better not to use it. I think Dr. Raghav has come because we have more now. So Dr. Raghav is also an ex-fellow from LV Prasad and he's currently a consultant at Sushila Netrale, Nellore. So thank you, Dr. Raghav, and please do give us some pointers and help us.
Hi, Pratima. Hi, Ananya.
Hi.
Great conversation going on. I really liked it. Just to add to what Pratima said, I think Pratima highlighted everything really well. So I think there's a lot of confusion about where to start, why antiviral, topical, low or oral, or the means to do it. If you understand the pathology, why it's happening, I think it becomes very easy. So whenever there is a virus on the epithelium or on the endothelium, they are live virus. Whenever you have live virus, you will need acyclovir in those cases. So acyclovir, uh, by all the randomized control studies which have happened starting from 1980s, what we got to know is it has to be used at least 5 times in a day. So even for a topical disease, even if you give 5 times oral, it will resolve. So oral or topical will not make a big difference. But the reason why we give topical over oral is because oral is very expensive. In a scenario like India, topical becomes easier, cheaper alternative to oral. This is something which is not available in the West, where in US, especially, or in France, where they use a lot more oral medications. In India, that's not the case. We get acyclovir easily, so we tend to use either oral or topical. I have seen in cases, even if you don't give either oral or topical, you still have a dendrite. Like you see many of the times, someone else is treating, not even seen the dendrite, but it still resolves because there are the natural immunity which comes in with the IgG and IgMs in the TFNM by themselves will take away the antivirals in cases of epithelial disease. So that is clear. Endothelium, again, you will have live virus. So again, the same rule applies. Whenever it is in the endothelium, you will again have to give acyclovir. But the problem with endothelium is all the acyclovir ointment or ganciclovir ointments, they do not penetrate the intact stroma. Why don't they penetrate? Again, it's based on the affinity towards hydrophilic or lipophilic uh, part of the medication we use. So because it doesn't penetrate, we are giving oral. This is why both in epithelial, endothelial, or uveitic, all three cases we are using acyclovir. And in stromal, we are like there are two major differences, which is necrotizing and non-necrotizing. The major difference again being in necrotizing stromal keratitis, you have live virus. Why? Again, the epithelium is already involved. The epithelium is open and the stroma is melting, then you call it as necrotizing. If the epithelium is intact and stroma is not melting, then you call it non-necrotizing. Exactly like how the name suggests. Because the epithelium is closed in non-necrotizing, there is no live virus, so it is only the viral antigen particle. Once you start giving steroid, like exactly like how Dr. Anuj said just now, because we are using steroids at a higher frequency, there is a chance to precipitate epithelial disease. So, in as a prophylaxis, so that you don't want an epithelial disease, you are giving antiviral. Antiviral in these cases has no role in treatment. It is only avoiding whether the patient will have a breakthrough epithelial disease or not. Once the dosage of prednisolone acetate or dexa, whatever you like, if it comes down to less than 4 times, even prophylaxis can be safely decreased. Only when the frequency of steroids is 4 or more, there is a high chance of recurrence. That's why we tend to give them. And in necrotizing, again, same thing, because the epithelium is gone, you have to treat it like live virus. Again, you give it 5 times because it's already melting, and acyclovir is a very epitheliotoxic drug. We tend to give oral form instead of topical form in necrotizing stromal keratitis. To understand the difference, I think you just need to understand what is happening at each step in the anatomy. And if you and heads is obviously the landmark trial, which actually looked into many things with respect to acyclovir. But we also, with all due respect to that, you'll have to understand that it was published in 1992. So of late, Dr. James Chudos has done a lot of work regarding HSV, and you can have a very clear-cut classification of what an epithelial disease is, what a stromal disease is, what an endothelial disease is. If you can read the article, I think it was published somewhere in 2020. Yeah, it's like a landmark article which clearly explains each of these diseases. Anybody who's getting confused about what this is, I think it makes a very big difference if you can go through the article. I hope I cleared some parts of it, because I have seen that the same question is being twisted and turned, and we are asking the same question. So I think the answer lies in understanding why it is happening. If you understand it, I think the treatment becomes very easy.
Thank you. Thanks. So we have had two experts who are clearing the air for us. So that is very nice. I think Dr. Aishwarya also made the same this which most of us have. So do you feel that the classification of the Neumiller and this is more for theoretical purpose, or in clinical also does it make a difference in your treatment?
I'm sorry, I did not get what Dr.
So
Aishwarya
so
said.
if you just classify it as a stromal rather than on the basis of its morphology, like into a numeral or an interstitial.
So yeah, I think there is some controversy there like there is a lot of nomenclature there, because I
Right.
think early days there have been very wide reports of different things. Somebody called it interstitial, somebody called as diffuse and everything. I think the major disciform keratitis was one of the terms which was used, and then the diffuse keratitis. I hardly think it doesn't make big difference. This is mostly theoretical for postgraduates. Obviously, you'll have to know because you have to write it in your exams. But from a day-to-day clinical point of view, I think the treatment remains the same. If there is stromal involvement, no epithelial, no endothelial, straight away the treatment is steroid with prophylactic aceclopine. It doesn't matter if it is at one localized, if it is diffused, or if it is disciform. And there are still much more weird presentations of herpes simplex, which cannot be even described with any of the three morphological classifications. Sometimes you, like Pratima was saying in the chat box, that they can be at many different levels. So it becomes very difficult to classify what it actually is. So for all practical purposes, if you can just remember epithelial, stromal, and endothelial, I think that would be more than enough to treat the patient at least.
Yeah, I would agree to the same. The broader classification would give you a better idea rather than going into each minor details.
So I think the anatomical classification as a epithelial, stromal, or endothelial is all that makes a difference in your practice.
Yeah, and you can add iridocyclitis to that so that you
Right.
can remember that you have to take IOP in each and every HSV patient.
Absolutely. So, Dr. Shubhangi, would you like to tell us what is the syndrome of raised IOP?
Brown-Macklin syndrome.
Okay, I don't know what is that syndrome, but Brown syndrome I just know for squint maybe. But which syndrome did you say, doctor?
Brown-Macklin syndrome.
I think the experts will take over.
So Brown-Macklin syndrome is basically when you have. I think it's a historical thing again. When there was ICC and ECC, which would happen, then decompensation would start more peripherally. Um, I mean, I have seen couple of patients. Probably I see one or two patients in a year, and they come because of bad SACS. And I don't think And are we talking about the differential diagnosis?
No, what I was looking for, the Posner-Schlossman syndrome.
Yeah. I think Brown-Macklin syndrome is something which is like, uh, so I think when we talk about differentials, it has to like match the clinical presentations. Brown-Macklin starts at the extreme periphery where you see something like a corneal decompensation as compared to an inflammatory herpes simplex kind of a stromal disease. So I don't think Brown-Macklin actually qualifies as a differential. You will see more bullae, you will see more Descemet's membrane folds, which are like more differential diagnosis for a pseudophakic bullous keratopathy rather than stromal. Uh, Pratima can comment. If
Yeah, so mainly what he was asking is about Posner-Schlossman syndrome only. So I think that is what he wanted to discuss among the PGs, whether you know about this syndrome or not, HSP associated with raised IOP.
Any other question, Dr. Pratima, you would like to ask Dr. Shubhangi or anyone or anything?
I think none from my side now because like we have discussed, maybe covered most of the topics. If anyone else wants to ask me anything or with like Dr. Raghav, then they can go ahead.
Yeah, I think those who have put in the chat box can directly use the mic. Or Dr. Shubhangi, if you have
Yes,
any
we have
doubt.
covered most of the topics from the chat box also. But if someone maybe
Can please small like a short note on metaherpetic or neurotrophic ulcers.
okay.
Like this is very confusing. Again, the nomenclature part also, and then the treatment part also.
So basically, for metaherpetic, Metaherpetic and neurotrophic again are one and the same thing. Okay, so as I said, like if you see in Crassus, there's an entire table where they have written different nomenclatures. Like the 4 5 names which they have given for the same condition, they have put it in one table. So you can go through that. So basically, neurotrophic would not be having any active viral load. It is mainly because, like, if you're treating HSV with a lot of medications, it can go into neurotrophic keratitis, wherein the nerves are defective. So the main problem would be the nerves now. The nerves have become very defective there, and the tear film is also defective in that area. So for the treatment of neurotrophic keratitis related to HSV, the main thing would be to supplement lubricating eye drops, maybe do a tarsorrhaphy if required. Sometimes if there is a non-healing epithelial defect, you can see a rough ulcer with rolled up margins, then you might need to go ahead with the AMG also. So that would be the main treatment. How it would appear, as I just said, it would be a rough looking ulcer with rolled up margins, and there will be no active infiltration. Like there can be a bit of cellularity or so, but no active infiltration in these ulcers. So you can treat them according to means you can boost up lubricating eye drops along with maybe eye ointment and treat it accordingly. And you can stop all the previous medications. Sometimes the patient might be having multiple medications, topical antibiotics along with steroids, along with some maybe topical antivirals. So you can stop all of that and just treat it like a neurotrophic ulcer. Anything Dr. Raghav would like to ask? I mean, still add into this?
Yeah, I think Pratima did cover most of it. I think there was one conversation, I think Aishwarya only was asking about antiviral 14 days and stuff. Why we use it for 14 days? Again, it depends on the viral life cycle. It usually lasts from 10 to 12 days. That's why I was trying to tell you, even if you don't use any medication, in 10 to 12 days, epithelial disease will resolve. There is no other way for it. So that is why we tend to use it for 14 days. But because there is so much ambiguity in how to treat this disease, we tend to use it for longer. I mean, some of us try to use it for longer. And sometimes what happens is even if the patient is not affording to take any type of prophylaxis, because the tablet still comes around 8 rupees a tablet, if I'm not wrong. So that will still be 16 rupees a day just for that tablet particularly. So some of the practices I've seen where they continue topical acyclovir at least once a day. Then when you see toxicity of the medication, topical medication you're using, usually we consider them as metaherpetic kind of neuropathy, or the other way around is neuropathy where you don't have active innervation. The active innervation is going down because again, virus, as you know, the pathology, again, it's gone into the trigeminal ganglion, it comes down, and along with the sensory innervation, it comes to the epithelium. So because now the virus load is present all throughout the innervation, there is a high chance of these patients having a neurotrophy. Neurotrophy is similar to any other neurotrophy in corneal conditions where you have in the major problem comes when you are trying to differentiate whether this is an epithelial geographic ulcer or this is a neurotrophic ulcer. The biggest difference in these cases is when you try to, like again what Pratima said, when you try to dual stain them with fluorescein and rose bengal or fluorescein and lissamine green. The base of ulcer stains with fluorescein while the margin gets highlighted with rose bengal. And you can see a subtle vesicular pattern in the periphery, even for a geographic ulcer, which tells you that it is active viral replication happening in the epithelium. Whereas in neurotrophic ulcer, you have thickened rolled margins, which can be easily made out. They're like punched out and you don't see any inflammation next to it. It's like almost the entire cornea apart from where the lesion is quiet, and the part where the lesion is, there is some inflammation. So neurotrophy is not active infection. That's why the inflammation is not as strong as it is an active geographic ulcer. So that would be the major differentiating feature. Treatment, whatever Pratima said, I think based on the duration of which neurotrophy is there, once it gets longer, you try to intervene, and AMG is one of the ways you do it. Also, we do a tarsorrhaphy. I think tarsorrhaphy is something I think it's like the easiest surgery you can do, where you are
Yeah.
just trying to decrease the palpebral fissure height. By itself, what happens is now more amount of tear film is staying back, or the more amount of tear is still there, which by itself will start healing the corneal epithelium. So I still do a lot of tarsorrhaphy in cases where I feel there is neurotrophy. But in case there is a non-healing ulcer kind of a picture, we also call it as persistent epithelial defect, where you have a large defect which looks like a geographic ulcer, but you have thickened rolled margins, elevated rolled margins. There you tend to debride the margins and put in an overlay AMG in these cases. That is the other wing of treatment. Yeah, it becomes very important to differentiate both these conditions. That's what I can say.
Okay. So I think that has been very good discussion apart from the topic that this neurotrophic ulcer, and as both of you said, that we can, if we are confused, we can stop all the treatment and then see how the response is. And because epithelial lesion is not a very dangerous lesion, we can still, if we are left and we are getting a patient who is already on treatment and we don't see a clear cut, then maybe stopping treatment and maybe putting on maybe a soft antibiotic and then seeing how the response is, to actually know whether it is a active lesion or not, is definitely a way forward. Are there any newer treatments for neurotrophic ulcer? Do we have any uh, drops or which may
So
work?
insulin eye drops
Yeah,
are
insulin.
like you can give insulin eye drops also, but like we have not done a lot of research on that. Like it tends to help in the healing process, but then again, like I have never tried it on my own. I've seen
Right.
people using it, but I never personally tried it myself, so I cannot comment fully about it. Read about it, seen it. I know it is a good modality, but personal experience is lacking from my side.
Yes, Dr. Raghav, would you like to?
Absolutely. I mean, I have not used insulin eye drops because I think we try to step up our therapies. Usually, we try to increase lubricants, give a soft steroid maybe under prophylactic antiviral cover. Doesn't work, then you're moving on to AMG and tarsorrhaphy. And I have never seen a neurotrophy which doesn't work with AMG.
Yeah,
So
yeah,
that is how far it goes. And we have limited experience. Even Pratima would have experience with autologous serum eye drops. These are some things which can really work as well.
yeah.
But just that every time you have to give autologous serum eye drops, you will have to again take the blood, separate the
Yes.
plasma. It's like a
Then centrifuge it.
complete thing you will have to
Yeah.
do again.
So
Yeah.
when we were in institute, we were using autologous serum quite commonly. But now out of the institute to get the blood, procure blood, then centrifuge it, then give it back to the patient, and then also rely that the patient will keep the autologous serum safely is something very difficult in private practice. So yes, in institution we have done it a lot, but in maybe private practice, I would like to try insulin in future. But I'm still like I never got the opportunity yet because with tarsorrhaphy alone and lubricating eye drops, AMG, I have seen most of the ulcers healing. So never required it yet.
So,
And also autologous serum eye drops, I don't think they are stable after 14 days.
Yeah.
So whatever you are collecting,
It,
you'll have to use within 14 days. If the
and you
ulcer
have to
heals, it
rely on the
heals.
patient also
Yeah,
that they will keep it like store
exactly.
it in the fridge door and
Yeah.
you cannot like trust them completely that they will definitely do it.
And in case they pick up an infection, again, you are easily
Yeah.
liable because again, it becomes an over-the-counter use as well. Right now,
Yeah.
even plasma-rich protein or autologous serum eye drops are not like FDA approved for ocular use, apart from few conditions like SJS or ocular cicatrizing pemphigoid. But otherwise, it becomes an over-the-counter use as well. So we'll
Yeah.
have to look at that part of treatment as well.
so in this lubricating, is there anything which you prefer, molecule, or it's just the less preservative, the better? Or do you feel any of the molecule work better than the other?
So
I would say
definitely
cheaper
less.
the better.
Yeah, I was going to say the same
Simply,
thing. That
it's like cheaper the better because you need to use it more frequently.
yeah, because if you are giving hourly lubricating eye drop and you are giving a preservative-free hourly lubricating eye drop, then it becomes very expensive. Hourly medications would finish off in a week's time, and if you are giving preservative-free, it will cost around 600, while a normal CMC would cost around 130 to the patient, or even sometimes cheaper. So they can use it weekly, and still it will cost, like in the entire month, it will cost amount to one bottle of preservative free. So it is always cheaper the better,
I
whatever
think
the patient can afford.
this is the statement by the reason why we don't have any sponsors to
That's true.
because there is no treatment which is cheaper and is best, as in today's scenario, even from anti-VEGFs
Usually,
to
if
contact
we are giving,
intraocular
yeah,
lenses. These statements are never heard, at least in the conferences
yeah.
or anywhere in public forum. Maybe
But
for
this,
personal discussion, yes, but
but this is the reality. I think.
yes,
Yeah,
I
I mean,
think
there are.
and most of
this
I
has
think
come
there
corneal,
are.
become a viral reel because this is a yeah, and anything with just for the sake because we have PG's neurotization. Does it have any role in this or any experience? Because I think LVP also they are doing a bit. So in your time, did you see or is it like or Tasso-Rafi only takes care?
so again, it's a very far-fetched thing. If tarsorrhapy, AMG, nothing is working, and the patient is having a long-standing neurotrophic keratitis kind of picture, or like like in especially in patients where they have like corneal anesthesia, they have a long-term condition, recurrent epithelial lesion because of corneal anesthesia. Those patients are the one where we usually target neurotization. Again, very difficult, not done very commonly because you have to procure a nerve from
Right.
another location, then transplant it. I've seen few cases, I have seen a surgery also, complete surgery of neurotization, seen the effects. Like it's a 50% to 70% kind of thing that sometimes, yes, they will work well also, but not something we would go ahead in the first go. Like it's for something very chronic, which is not resolving at all with the normal like AMG and all. And as Dr. Raghav said, usually in my personal experience also, I've seen that AMG, tarsorrhaphy, all these works for HSV related neurotrophic keratitis quite well. These surgeries which we are thinking of, neurotization and all, are more for more of like for congenital conditions, like
Okay.
congenital corneal anesthesia, not regularly done for HSV associated neurotrophic keratopathy, not very common.
Sure.
Yeah, anything, Dr.
I think
Raghav?
one point I want to add is, fortunately or unfortunately, herpes simplex usually comes to one eye. So the
Yeah.
other eye is usually well spared, and if you take good care of the other eye, I don't think we need to perform such an extensive procedure because it's not an easy procedure. It would run for 5 hours. I was fortunate or unfortunately part of the procedure as well, where we would all sit down for 4 5 hours and do the procedure. Um, yeah, it like Pratima said again, for some conditions like hereditary autonomous neurosensoropathy like Hassan syndromes, type 4, and some other conditions where you have congenital corneal anesthesia bilaterally. I think that is where you can experiment on them because now you are just trying to save some amount of vision in this eye. But for as far as neurotrophy secondary to HSV is concerned, it usually affects one eye, and so I would still not do such a big procedure because end of this procedure as well, there is a good chance that the virus can come back into the neurotized nerve endings as well because it's hiding somewhere else. The basic pathology is it's hiding somewhere else, so it can always show up even in the new nerves you have put. So I wouldn't really want to do a neurotization for HSV related neuropathy. Tarsorrhaphy works brilliantly. I mean, it's I think underappreciated. Again, the cheapest of the procedures you can do. Tarsorrhaphy works brilliantly. Once you do a tarsorrhaphy, the chance of having an epithelial breakdown is very less. So in case you still have an epithelial disease, it's usually active disease. So I am more comfortable doing a tarso in these patients. And I have seen most of the times neurotization is combined with with a tarsorrhaphy. It's not like when we do neurotization, you have a wide, big eye. We definitely try to combine it with a tarsorrhaphy, where tarsorrhaphy stays at least 6 months before you start seeing some amount of sensation on cornea.
Yeah.
So taking all in consideration, I think still tarsorrhaphy overscores any other procedure for neurotrophy.
I think just for the completion's sake, if you want to write in your theory or maybe if ask for more procedures, maybe you can mention, but practically it is of limited use currently. So Dr. Shubhangi, Dr. Raghav was saying it is very rarely bilateral HSV. Do you know conditions where you would see bilateral HSV?
Immunocompromised patient, AIDS, HIV.
And
Congenital.
I think in atopic keratitis, we see them more bilateral, right?
Yeah.
Maybe
All
we'll
three conditions, immunocompromised childhood, as she said, congenital and atopic. All
Yeah.
the three conditions could have bilateral
Yeah, because
HSV more
these
commonly.
can be asked in Viva if whenever you say as a unilateral pathology. So I think we have covered in-depth viral, and we have gone to the depths of endothelium and come back with an intact epithelium. So we've done really good, and thank you, Dr. Pratima and Dr. Raghav, for joining in and sharing your expertise and clearing all the doubts. Because it is viral, we are always ifs and buts. Yes, we can use this, we can use that, but what actually works and what should be done is amazing. And thanks again, Dr. Shubhangi, for taking up this case and presenting it so well. So thanks a lot. And if any questions are there, please do post in the group, or and we'll share it with Dr. Pratima and Raghav and get expert opinion. And regarding James Shodosh, I have already shared the article in the group, so you can read it. And so we'll take off and let everyone enjoy the festive spirit. Okay, thanks a lot. Thank
Okay.
you.
Thanks a lot.
Bye,
Thank you,
Pratima.
sir.
Thanks
Thank you.
for
Bye,
inviting
Pratima.
us.